right, so I just want to start this by acknowledging that this talk is derived from the chapter in the guidelines that I put together with Neelam Giri from the NCI, so many thanks to her for all of the discussions that we had over these topics. And the idea behind this chapter, and I guess the idea behind this talk, is really this is the Cliff Notes version of what routine subspecialty evaluations testing should be done during the pediatric age period, loosely defined as up to 18 years, although there is that gray period for a few years after that. But that will be for my colleague Dr. Riley to talk about a little bit in terms of adults screening. So when I mentioned something about Cliff Notes to my own kids, they looked at me and said, "What are you talking about?" So just in case I lost somebody with that, this is like the overview wiki page of screening for telomerase syndrome patients. All right, so first and foremost, the most important thing is there's not just one appropriate screening program for all patients with TBDs. We now know that there are many distinct syndromes, different gene mutations convey different risks, and then screening interventions may also carry distinct risks in different patients, a point that Dr. Batuch made earlier today. When we set up this chapter in the guidelines, the concept is we wanted to differentiate two general subtypes of patients. The first is patients who we thought would require the full screening. And by full screening, this means it includes some of the more invasive procedures that we do to check for disease complications, and examples of those are things like bone marrow biopsies and endoscopic evaluations. And so for the patients with TBDs who we think need the full screening, these are patients who are known to have very short lymphocyte telomere length and at least one of presence of a known pathogenic mutation in a TBD-associated gene, classic mucocutaneous features of dyskeratosis congenita, or similar classic features of another telomere biology disease, such as Revesz syndrome, Hurrell-Friderichsen, as well. We delineated a second category of patients who we thought should have at least partial screening done. And these are patients who are suspected to have a TBD, but in whom we haven't been able to identify either a gene mutation or perhaps don't have all of the physical features of a classic telomere biology disease, or patients in whom they have a TBD-associated gene variant, but that variant is not associated with severe manifestations in the pediatric age range. And so while this all probably sounds clear as mud, I'll say two things. Number one is if you're not sure what you or your child or your other family member has, talk to your physicians about which category would be better to apply. And just to give you a couple of examples of what we're talking about for the partial screening category. So for example, a patient who lacks very short telomeres but does have some features of a TBD and has a variant of uncertain significance in a gene. Patients who have short but not very short telomeres, who have physical features and have no pathogenic variants that we can identify. And then, for example, patients who have heterozygous RTL1 mutations, where we know that patients are going to be at risk for pulmonary fibrosis, but do not have clear symptomatology while they're in the pediatric age range. All right, I talked about this, emphasized this earlier, and I'll emphasize it one more time. A medical home is critical for coordinating screening and making sure that we're keeping up with all the screening that's needed. Some centers have actually developed multidisciplinary clinics where you can see multiple subspecialists in the same clinic on the same day. And there's some advantages to that in that you can knock out visits in one day. The one con about that is it takes a lot of effort to bring together all of those subspecialists in a single day. And so when we set up clinics like that, you're usually confined to only doing that 4 or 5 times a year. And if that is not on a date where an individual patient can come, then they don't derive the benefit of that. And so what we do for the most part, and what many centers do, is offer coordinated complex scheduling when we can. All right, so now I'm going to scatter shoot through the different types of screening that we need. And just to orient you to what a lot of these slides are going to look like, the top table is the recommendation in the guideline for patients who we think need the full screening platform. And I'll delineate caveats for patients who we think can do okay with the partial screening platform as we go through. So Dr. Bertucci touched on this a little bit earlier today. CBC monitoring should be at least every 6 months while blood counts are normal. And then bone marrow monitoring is done at diagnosis. And then in the guidelines, what we suggested is if there are no severe abnormalities in the bone marrow, to then only start yearly screening after 10 years of age. CBC monitoring is useful for screening for bone marrow failure and MDS, but it also screens for a couple of other less common but recognized issues, one of which is there are some patients with TBDs who have immune dysregulation, and so you can actually get autoimmune cytopenias. And then particularly as patients get older, there can be issues with bleeding for which CBC monitoring is useful. So if you do detect cytopenias, that increases the frequency of screening, and Dr. Bertucci covered that earlier today. For patients who are post-stem cell transplant, you're not necessarily out of the woods of needing CBC screening, and the reason for that is specifically because there are these bleeding risks that patients as they get older can have, and so it's still recommended that somewhere on the interval between every 3 to 6 months we get a CBC. So for patients that are in the partial screening cohort, if they have had several normal CBCs and we have a question as to what their risk is for developing severe bone marrow failure, we'll actually decrease the frequency of CBC monitoring to once a year. For the bone marrow monitoring part of hematology screening, again, Dr. Bertucci covered this. These are all of the reasons that we do bone marrow screening. Notably absent from this is detection of how cellular the marrow is. We only need to do a bone marrow once, really. If you have identified hypocellularity, we don't compare the cellularity on multiple successive bone marrows, and we could talk about why that is a fraught thing to do. Most of the ongoing screening of bone marrow is really to look for changes associated with MDS. So for full screening patients, if a baseline study is abnormal, we will start repeating yearly. For patients who are diagnosed at a very young age, we do not do the initial bone marrow evaluation until at least age 3. For patients in the partial screening category that I mentioned at the beginning, we still recommend getting a baseline study to assess if hematopoiesis looks normal. If it is normal, we will not do follow-up bone marrow evaluations for these patients unless they develop new cytopenias. Oops. And then post-transplant, routine marrows are not recommended after bone marrow transplant unless 2 things happen. Number 1 is the reason for the transplant was that a patient had developed MDS or AML, and then many centers like ours will do a couple of post-BMT surveillance marrows. And then otherwise, if a patient has developed unexplained cytopenias after the transplant, and we need to make sure that the bone marrow graft is functioning well, we'll do a marrow. Okay, immunologic screening. As you all know, there are immunologic abnormalities that have been associated with telomere biology diseases, and so every patient in the partial or full screening category really should have a baseline immune function assessment. What are the studies there? And this might be too much detail for some, too little detail for others. We like to examine all of the subsets of the immune cells that are there to see what's represented. So those are the different fractions of T cells, B cells, and K cells. And then we like a few functional tests as well. So how much antibody is being produced and how much antibody can be generated specifically to the vaccines that a patient has received. That tells us how well the immune system is functioning. If your screening is abnormal, we recommend establishing care with a local or a regional immunologist. And it's notable that immune function may evolve over time as well. So If a patient is doing well in early childhood, few infections, and their immune function is normal, but 5 years later they're starting to have recurrent viral infections, it sometimes is worthwhile to repeat immune testing. Vaccines, very importantly in terms of routine care. If a patient has normal immunologic screening, we are cleared for vaccines, and we think that it's very important to get HPV vaccination with the standard pediatric schedule because of the possibility that some of the solid tumors that will be discussed tomorrow could be associated with HPV. If you have abnormal screening, though, it's very important to consult with an immunologist before you go through the entirety of the pediatric vaccine schedule, particularly the live virus vaccines, so your MMR and your chickenpox vaccine, to make sure that we think that it's safe to administer those vaccines. And then post-transplant, the one notable thing about patients with telomere biology diseases is oftentimes we have observed that the total numbers of T cells and B cells of the immune system stays somewhat low in patients with TBDs. We don't fully understand why that is. That might be something that Dr. Agarwal will talk about a little bit more tomorrow. But one of the important things for us that we now understand is that we need to assess for functionality of the immune system even in the context of relatively low numbers of cells, because we might still be cleared to restart vaccinations post-transplant, and this has implications for the antibiotic prophylaxis that we use after transplant as well. So this in our center is something that we do in coordination with our immunology team. All right, endocrinology. Basic assessments of growth, bone health, and thyroid function should happen at diagnosis and yearly. These are quite simple things that can be done not necessarily by an endocrinologist, but could be done by a primary care physician and even the treating telomere disease expert. We do recommend that endocrinology consultation be started for every patient by age 10, and patients who have significant growth delay or compromised bone health parameters or who are receiving androgen therapy need earlier initiation of endocrinology care. And then a DEXA scan, which is a measure of bone density. We recommend starting those at the onset of adolescence and continuing those every 3 to 5 years if the initial screening is normal. A couple of other things from this, on the left here, on the bottom, thyroid screening, those are the tests that we send. Growth, if patients have significant growth delay, as we're getting patients into endocrinology, we will sometimes send a bone age study to figure out if that growth delay is what we call constitutional, meaning they're just slow growers, or if we think that there is a problem with growth. And then you send a variety of studies, including something that's called a stim test, to look for function of growth hormone. Some patients with telomere biology diseases have short stature because of growth hormone deficiency, and some have it because of factors that are independent to it. And so this testing helps to predict whether a patient could potentially benefit from growth hormone therapy. There are pubertal progression hormone studies that can be done. Everybody should get an annual vitamin D level to help with bone health. And then patients with specific types of telomere syndromes, including those who have something that's called Coates Plus, are at increased risk for bone fractures. And so for patients who have a history of bone fractures, it's very important to have a multidisciplinary bone health evaluation to talk about types of therapies to prevent refracturing, including something that's called bisphosphonate therapy. All right, liver screening. We talked a little bit about this earlier today too. Liver function testing, just blood testing at diagnosis and once a year. We recommend a baseline liver ultrasound starting at age 5, and which may be up to yearly. Any abnormal screening gets us talking with our hepatologists and gets you a consult with a hepatologist. Patients who are on androgen therapy need more frequent liver monitoring because of the risk of adenomas that you can see and other liver abnormalities. For patients who fit into that partial screening category that I mentioned at the beginning, sometimes we start liver ultrasound screening a little bit later and we do it less frequently. And then anybody who has an abnormal ultrasound screen, as we talked about earlier today, we are now recommending getting an elastogram or an elastography study. What elastography does, as Dr. Meyer said earlier, is gives you a quantitative metric of how stiff the liver is. And that metric you can actually follow over time. So whereas the impression on a radiology report can vary based on who it is that's reading the ultrasound as to whether there's more stiffness, there's less stiffness, there's more echogenicity, there's less. That elastogram value actually gives you a quantitative metric that you can follow over time. And then, again, as we discussed earlier today, hepatopulmonary syndrome, there's no routine screening that's currently recommended at the moment. But strongly recommends to pursue screening if either the symptoms develop below new onset shortness of breath without a known infectious cause or evidence of what's called portal hypertension. In the screening evaluation for this, again, as Dr. Myers mentioned earlier today, is what's called a contrast echocardiogram or also a bubble study. All right, lung pulmonary screening. We recommend that patients begin assessments including spirometry. Spirometry measures how well you're able to push air in and out of your lungs. Diffusing capacity measures for fibrosis directly, how much space is there between the air sacs in the lung and the blood vessels in the lung. And so these are the two key components to pulmonary function testing screening for patients with telomere biology diseases. These maneuvers, particularly the diffusing capacity, are very hard for young children to be able to do. And we have found that, at least for that parameter, age 10 is a good time to start initial screening. And if you have a normal initial screen, we'll do it every 2 to 3 years. If you have symptoms, that's when we would recommend CT imaging or other imaging. There are challenges with doing CT scans and the concern about long-term exposure to the radiation with those scans. However, there are elements for the diagnosis of pulmonary problems in patients with TBDs for which there are not other sensitive tests, and so once in a while a high-resolution CT scan is required. Young children who have a history of a lot of infections or lung disease, we can start doing the spirometry aspect of pulmonary testing earlier. That's sort of the blowing in, blowing out, getting a sense of how well the lungs are functioning. Sometimes we can start doing that by age 5. Sometimes we can never do pulmonary function testing because these are complex maneuvers, it requires cooperation, and if a patient is developmentally unable, we aren't able to get accurate metrics. And in those cases, we're probably more likely to rely upon imaging findings. Very importantly, it's important to closely track pulmonary function testing after a bone marrow transplant, because the stresses of going through a bone marrow transplant can greatly change the pre-transplant pulmonary function assessments. All right, GI and nutrition screening. This really is highly dependent upon symptoms. There are a couple of evaluations that are thought of as standard. Fecal occult blood testing starting at age 12. Upper and lower endoscopies at symptom onset or age 18 and repeated every few years. GI issues that screening can diagnose include a variety of things. So stenosis or narrowing of the esophagus, inflammation of the gut, which is enterocolitis, arteriovenous malformations in the GI tract, cancer, and of course bleeding. The reasons why you might want to pursue an earlier endoscopy if you haven't already started it. For the upper tract, there would be symptoms of narrowing of the esophagus, right? So solid food avoidance, difficulty swallowing, regurgitation of food, not being able to pass it. And then lower tract includes diarrhea, blood and stool, pain with defecation as well. And post-transplant, we have to be post-bone marrow transplant, I should say, we have to be very careful with GI symptoms and have a very early threshold to do endoscopic evaluations for patients because some of the complications of transplant, including graft versus host disease, can cause a progression in telomere disease-associated symptoms in the GI tract. All right, ENT dental screening. We recommend routine dental assessments by age 3, at least every 6 months. For patients who have full, meet that full screening category, we recommend nasolaryngoscopic screening, easy for me to say, at age 10, and going every 2 to 3 years to screen for head and neck cancer. Patients qualifying for partial screening, we do not do nasolaryngoscopy unless there are concerning symptoms. If concerning lesions are identified, lesions that persist more than 2 to 3 weeks should be biopsied. If positive, got to get to oral surgery in a hurry. If negative, we rebiopsy with any change in size or appearance. And anybody who at any point has had history of suspicious lesions somewhere in the head and neck region, we recommend increasing the frequency of nasolaryngoscopy to once a year. Dermatology screening is somewhat similar. We started at age 5, we do it yearly. There are a variety of things that dermatologists can be helpful for, not just the risk of skin cancer, but also management of hyperkeratosis, that thickening of the skin, particularly in the hands, poor wound healing, which can be a symptom of a telomere biology disease as well, alopecia, hyperhidrosis. And then here are some maintenance skincare recommendations as well. I think these are probably familiar to you. Eye screening, routine eye exams by age 5, and then, as I was discussing with a couple of folks earlier today, retinal exams. Retinal exams are important part of the screening, but specialized visits with a retinal specialist are recommended for certain types of telomere biology diseases, including Coates plus and Revesz syndrome. Opto exams also screen for lacrimal duct issues, which affect tearing, turning out of eyelids, which is and turning in of eyelids, and loss of eyelashes, and then corneal scarring, erosions, and conjunctivitis. And post-transplant, some of these issues often get a lot more significant, particularly with respect to dry eyes and cataracts. And this just mentions the retinal vascular monitoring. And then neurologic screening, these are symptom-based, so there's no necessarily recommended neurologic screening for all patients. However, any patient who has an abnormality on a neurologic exam that we do in the hospital, we recommend at least getting a baseline brain MRI. There are certain TBDs that are at higher risk for abnormalities to be found in the brain, either calcifications or underdevelopment of certain parts of the brain, which is the case for patients who have Heuerl-Friedrichsen syndrome. And so several of the reasons why we consider neurologic evaluations are listed here: onset of developmental delay, tremor, focal weakness, or certainly seizures. And then last but absolutely not least, mental health screening, and I alluded to this a little bit in my prior discussion. So patients who have symptoms of behavioral disorders at the time of diagnosis should be established with mental health providers. And then all patients, we recommend mental health screening starting at age 10. All right. Thank you.